Hello, old friends. I'm sorry I couldn't join you for this meeting since I'd promised to be elsewhere at the same time. Anyhow, I will have, a recorded lecture today, I will talk about marginal bone loss and oral implants. In fact, the birth of a new discipline was when this is the original titanium chamber that Brennemark found impossible to remove from a research animal, the discovery of what would later be called osseointegration. The year was 1962, and only 3 years later, in 1965, the first patient was treated with bone-anchored implants. Brennemark's discovery was not welcomed by our dental profession of those days. They knew that the oral cavity is not clean and saw it as impossible that oral implants can survive for long. In fact, others who tried oral implants had failed in great numbers, and in retrospect, the critical attitude to Brennemark's implant was not surprising. However, with time, clinical results of osseointegrated implants were quite good, and in Sweden they were found clinically acceptable in 1977. Internationally, the year of breakthrough for osseointegrated implants was in 1982 following the Toronto conference. And for many years thereafter, oral implantology at Brennemark was recognized as a generally successful treatment for patients without teeth. At Gothenburg University, we started training clinicians, mainly from overseas universities, in how to place osseointegrated implants by the early 1980s. But a second wave of criticism followed in the first decade of our new millennium, when many implants were said to be suffering from disease. Some 10 to 15 years ago, several papers were published by Fransson, Kjolsland and Rosland and co-workers claiming that implants suffered from a disease entitled peri-implantitis, threatening anywhere between 6 and 50%, depending on the definition of the alleged disease, of all placed implants. A new science, osteoimmunology, was introduced at about the same time as periodontists started reporting high levels of an alleged disease around oral implants. The skeletal system and immune system seem independent of one another, but are, in fact, inseparable and closely related, wrote Fattori and Tele in 2012. What does this new knowledge of osteoimmunology mean? To put ligatures, to give you one example, around implants has been regarded providing the experimental evidence that marginal bone loss is a result of bacteria alone. Behind the statement of only bacteria to be causing marginal bone loss were many studies with ligatures in dog models. Bone resorption was associated with numerous bacteria alone, but let us ask the question, what is a ligature? And you are right, a ligature is a classical foreign body. We decided now to place ligatures in a bacteria-free environment to find out what happened in the long bones of animals under very aseptic conditions. Rabbits and mice were used as research animals. You see, bone resorption was observed around ligatures in the tibia, a foreign body, the ligature. On another foreign body, the implant is causing marginal bone loss despite no bacteria. The immune reactions were significantly increased to the implants with ligatures compared to implants without ligatures. Ligatures are neither bioinert. We learned from this that the immune reaction to implants is positive for clinical outcome, but in case the immune system is imbalanced, overactive, then we may see a shift from bone shield off to bone resorption. And therefore, to give you a clinical example, we need not look for bacteria in cases of cement leakage. Cement is a foreign body on another foreign body which will elevate immune reactions. It represents no primary disease. This case was regarded to represent peri-implantitis, but when tissues were opened up, it was evident that marginal bone loss was due to cement remnants, with initially is no disease, but instead an adverse immune reaction. That's what it causes. However, if you don't remove the cement in a case like this, then we may with time see the immune system decide on implant rejection, but that later will be followed by a bacterial attack. Plaque and biofilm has been regarded with the background of alleged implant disease. But in reality, when this has been studied by others, Göthberg, for instance, found that bone loss decreased when plaque index and bleeding on probing increased. So it was vice versa. And this was further found by Menini and co-workers who followed implants for up to 14 years, no fewer than 331 implants, and found again lower bone resorption with increasing plaque index. So it seems to be the opposite. A cause-effect relationship between plaque accumulation and peri-implantitis has been difficult to validate, wrote Coley and Yemt in 2020. All MBL after the implant's first year in situ has been regarded depending on disease. In reality, a great number of different factors, most of them unrelated to disease, may cause marginal bone loss. There are a great number of factors, including smoking, poor surgery, poor prosthodontics, genetic disorders, and broken components, titanium wear, to give you a few examples, and also pharmaceuticals that combine and they can cause marginal bone loss. If they so do, the immune system will be activated, and when that happens, the influence between the osteoblast and osteoclast will be deciding whether we have a lot of bone resorption, and that is governed by the immune system alone. The osteoclast and the osteoblast, they have a coupled function, and here you can see blue spots, alkaline phosphatase, indicative of osteogenesis, and very close by red spots, that is acid phosphatase, indicative of bone resorption. There is a delicate balance between bone-building osteoclasts and bone-eating osteoclasts, and they act in a coupled manner, as I said. But it depends then the outcome, which cell that dominates. And we know today that these cells are not simply involved in bone homeostasis, but are also a functioning part of the immune system. They are immune cells, the osteoblast and the osteoclast. This is how we define osseointegration today. It's a foreign body reaction where interfacial bone is formed as a defense reaction to shield off the implant from the tissues. There's always a risk that osseointegration, bone shield off, may be challenged due to the sum of traumatic factors to the implant. And the immune system may then start marginal bone loss, which indicates a gradual shift from bone shield off demarcation to rejection. Build-up osseointegration and breakdown marginal bone loss of bone is primarily dependent on the immune system, nothing else. Let's look at the series of events that may follow the placement of an oral implant. If you place an oral implant, we'll have the immune reaction, bone demarcation, or if you prefer, bone shield off. That may result in implant survival for more than 50 years. That has been documented in the literature. But alternatively, we may see with time, if not that commonly, an immune system imbalance due to multi-factor outcome. And that may result, if the imbalance is continued, in rejection and lack of bacterial defense. In 1993, I attended a consensus conference arranged by prosthodontists in Canada, and they came to the conclusion that marginal bone loss and implant failure depends on overload alone. 3 weeks later, I attended another consensus meeting arranged by periodontists in Switzerland. They saw marginal bone loss and implant failure to depend on bacterial infections. And this conflict to part still is at hand today, 28 years later. Today, I see the prosthodontic as well as the periodontic theories as great simplifications of what really causes marginal bone loss and implant failure. The oral implant is a foreign body to which the body defense mechanism must react with either rejection, dissolution, resorption, or demarcation. But dissolution or resorption of a titanium implant is unlikely, therefore we mainly see bone shield off of the foreign body. It has osseointegration. That is an immune reaction to separate the implant from the tissues. The other possibility without titanium implants is a rejection of the foreign body, characterized by unstable implants due to soft tissue embedment. The body tries to isolate foreign materials in the soft tissue by forming a fibroblast-derived capsule around the material, in bone tissue by osteoblast-derived bone around the material. The fibroblast and the osteoblast have the same origin, the mesenchymal stem cell. Let us now go through some factors that may combine to a clinical threat for the implant: primary corrosion, secondary corrosion, and implant contaminations. Primary titanium corrosion is probably inevitable in the tissues, at least in the first 3 or 4 weeks. That is what we call primary corrosion. Leaked out titanium may be surrounded by soft tissues that we can see on this image to your right. Wennerberg used SIMS and high-resolution spectroscopy to analyze primary corrosion in form of titanium leakage in relation to implant surface roughness. And here she had a machined implant, and you see here the distance from the implant surface in micrometer on the x-axis, and then you have the amount, the intensity actually, of the titanium outside, and you can see that it's detectable down to 800, 1000 micrometers away from the surface. And now when you roughen up the surfaces, it did not seem to bring about any sort of greater detectable leakage of titanium, but it was a leakage of titanium, it was corrosion indeed. Secondary corrosion has been demonstrated in some studies, as for instance by Pettersson in his thesis of 2018, but we currently do not know how common this problem is. Mechanisms behind secondary late corrosion are currently being investigated at several research centers, since it may pose a particular threat to osseointegration. Implant contaminations is the third factor. They may combine with corrosion products to cause marginal bone loss and other implant problems. Organic contaminations may contain a great number of different materials of a potentially harmful character. And we can't see them alone. Again, they combine with other problems such as primary and secondary corrosion. They may initiate implant reaction by the immune system of the body. This type of problems in the long range may cause the immune system to change its reaction over to rejection instead. With those words, I greet you and hope you will have a very nice meeting. Sorry I couldn't join you. Thank you very much.